and Mental Health in OBGYN. Now, let me brief you about SIMSOG. SIMSOG, Society of Indian Medical Students of OBGYN, is committed to fostering interest in OBGYN through advocacy, academic discussion, and leadership opportunities. Since its inception on Women's Day, March 8th, 2024, it has grown to over 2,000 medical student members across India. Now, I would like our SIMSOG advocacy team to quickly introduce themselves. Nisa, AO Nisa.
Good evening, everyone. My name is Maisa, and I'm Administrative Officer for Advocacy. So here we are for the seminar, and I hope you all stay put. Thank you so much.
AO Divya, are you here? Good evening, I'm Bharati. I'm an administrative officer at SIMSOG. And yes, we were so interested to visit this panel discussion. We will put to many of our people who have joined us. Okay, thank you. And now it's my privilege to introduce our distinguished panelists, Dr. Veena Satyanarayana, Additional Professor of Clinical Psychology at NIMHANS, specializing in women's mental health and psychosocial care. Next, we have Dr. Kamaxi Bhate, former professor at KEM Hospital, Mumbai, with pioneering work in community medicine, gender policy, and health education. Next, Dr. Padmaja Samant, Professor and Head of OBGYN at KEM Hospital, Mumbai, a leader in high-risk obstetrics, bioethics, and women's health advocacy. Next, we have Dr. Shikhanshi, former Assistant Professor at TNMC and BYL Nair Hospital, Mumbai. She has authored several research publications and is a dedicated advocate for female wellness, reproductive rights, and mental well-being. We are truly honored to have such an esteemed panel with us today, and we look forward to their insights on this important topic. Now, as we set the stage for today's discussion, it's important to highlight the core theme, that is somatization. Somatization, where psychological distress appears as physical symptoms and is especially significant in women's health. Conditions like PCOS, chronic pelvic pain, dysmenorrhea, and endometriosis are not only medical concerns, but are also closely linked to stigma, stress, and mental well-being. Our panel today will help us explore these overlaps and also ways to approach them with greater empathy and clarity. Now, let's start with the questionnaire. The first question is open to all the panelists. Anyone may take it up. Why is it important for clinicians to understand how physical symptoms can affect mental health, and why and how mental health can influence reproductive health?
I thought Padmaja is a clinician, so maybe.
Okay. So the question is physical, mental, and reproductive, right?
Yes.
I was, the woman's body has a unique either privilege or risk, whatever you call, of changing its hormonal milieu every month in different phases of ovulation and menstruation. And each of these hormones have got a great influence on the central nervous system. Let us not say mental or emotional health just now. Let us see what objectively neurological impact is. There have been studies which have shown that during pregnancy, there is a lot of change that occurs in the gray-white matter in the brain. And some of these effects are longer lasting, some are for that phase of pregnancy, lactation, and a few months postpartum. So when the body is going through so many transitions, not once, numerous times, as many number of pregnancies and deliveries she has, the number of abortions she may have, the number of terminations of pregnancy that she may have, the number of ovulation inductions, the number of infertility work that she has. Every time her body is pumped with all these neurochemicals. They are not considered as neurochemicals, but definitely they work on those the central nervous system. It is obvious how it is going to affect the um, expression of her changes in the neurological milieu. This is first part. Then how it affects her reproductive health. Reproductive health, let us divide into two: sexual health and reproductive health, because it is unfair to a woman to say reproduction is her job, when reproduction is an automatic fallout or automatic result of sex. And when we consider that both men and women have sex, and women have this additional burden of reproduction, we will understand why she has so much impact of her mental health on the reproductive health, which is actually modified, which is actually treated, which is actually changed with so many other social factors, social needs, etc., etc. Mainly human female. Now we actually modify and change animal reproduction also, but all these decades or centuries, animal reproduction was not really played with much. Now that is also modified by humans, but women's reproductive physiology, women's reproductive anatomy, women's reproductive pathology, everything has been changed with, or everything has been intervened by or interfered by medicine so much that it definitely has a lot of effect on her reproductive health performance, her reproductive well-being. So that is what the whole picture is. And unless as a clinician we take into account, and we never really take into account this part, we generally, woman comes with one reproductive health complaint, our women do not talk of sexual health complaint. When they come with reproductive health complaint, we just look at her uterus, pelvis and ovaries, at the most thyroid or something, and then we start treating her. But she, as an important decision maker and stakeholder of her sexual and reproductive health, it is rarely considered, and that is where I think we have failed.
Dr. Veena, do you want to add anything?
Yeah, sure. At the outset, let me thank SIMSOG for having me be a part of this very interesting panel on mind and body. I think mind and body interaction is very important because I work in a tertiary care mental health hospital. So typically when women come to us, to NIMHANS or to any other tertiary care facilities, they would have consulted many other people, and then they would probably come to us, expecting us to resolve some of their long-standing concerns, by which time their concerns are also fairly chronic. So it's very important for us, particularly in today's world of specialization and super specialization, that we, keep in our mind the broad interaction of the body and mind, and also sometimes remind ourselves of the general systems theory, where different systems mutually impact and influence the other. And having said that, it would be very important, particularly for me, to also ensure that physical health concerns or, physical etiology is ruled out And I can safely assume that the women that I see more or less have a more psychological etiology to their problems. So oftentimes we are also very concerned to not miss out something that could be organic. So I think that becomes very important, because oftentimes it could also be psychotropics that women are on that could be contributing to, let's say, dysmenorrhea or any other, abdominal and pelvic symptoms that they experience. So I think that is likely to be on the forefront of my mind. But having ruled that out, it will be important to see what other contributing factors, which could be psychological or social, are also impacting this woman. For instance, the quality of the marital relationship, any adverse experiences, including sexual experiences and traumatic events that a woman has been exposed to, all of that then becomes very important to a practicing clinician, particularly in these tertiary care mental health facilities. I'm sure we can get into the specifics as we go, but to, open the discussion, I think today's panel is very important in that sense, because it's looking at how bodily symptoms impact mental health or emotional health, and how emotional and mental health symptoms also have a role to play with any bodily symptoms. Today, stress is implicated in pretty much everything, as a significant concern that could worsen any physical health problem as well. So I will, stop here, and we can get into the specifics later. Thank you.
Yeah, thank you to both of you. That was very insightful. Next up, we have to Dr. Kamaxi, ma'am. In your experience, what is the first sign that somatization is contributing to a patient's OBGYN symptoms?
I thank Samsung for calling us and talking to us. I thought that it is a very progressive step, because it's not just patient coming, taking paper and we prescribing something and sending them back. It's trying to know the patients from our perspective to understand. Now, signs could be anything. It's not first sign, second sign, might differ with everybody. We have to know who are the people who get more affected by this. These are the people, like these are economically modest people, and these are slum dwellers, socially compromised. They could be Dalits, they could be religious minorities, disabled, and affected could be more even boys also. We have not considered because it's gynec, but I'm just saying that we need not feel that only girls are exposed to this kind of sexual assault. But whatever studies Gender Resource Center has done, it has shown that even municipal school boys, very young, they also experience. Here, even working women who are on the roads, it is not only the working women means taking a bag and going to the hospital or offices. So women who are on the roads working as vendors, working as like those who are building houses, those making bricks, etc., farm workers also, these are the people who are also affected. And they can be affected anywhere. It is not a one place which is safe for them. There are no safe places for some people. Like we can't say which is a safe place for women. It's not safe. Some places, and for some people, there are no safe places. Like for example, like I can say you that India has in 2019, India was considered as one of the most unsafe country for women, and it has not been much better anytime. Surveys in 2023 have said that 40% of the women get scared to go travel at night, even in their own cities. They don't feel safe even in their own houses. We have to realize that it's our responsibility to even find out what is happening before we brand them. That it could be, earlier it used to be called psychosomatic, and sometimes we used to drive them home, which is not the right way of doing it. One has to try and find out what is happening, and it cannot happen unless it cannot go on unless we talk to them in detail about what is their work they are doing, what are the difficulties they are facing, or they have faced something in their childhood. If sexual assault done by somebody who is from her family, it's very difficult for them to even come out of it. Their families also don't want to come out of it. Even if it is a child, even if it is a POXO case, they don't want to go to police station. So we have to realize all that. While we are talking to them, we have to understand that the family will get so scared that they may not come back to us. We have to understand that they could be hiding also, but still it is important to talk. Thank you.
Thank you, ma'am. Building on that, Dr. Shikhanshi, how do these presentations differ from typical pains complaints?
Good evening, my esteemed seniors. I'm feeling very lucky to be a part of such a panel with such esteemed doctors, Dr. Veena, Dr. Kamaxi, Dr. Padmaja, madam. And being the youngest, I have been actually associated with this organization, SIMSOG, since the conception of it. And I've been a part of it. So uh, this has been a very nice, this whole topic. We are usually covering some topics which are not usually covered by other bodies or other organization, and it is basically for students to help them be more precise with their clinical build up and clinical academic later practice in their life. So this topic is also very important for all the clinicians, all the students who are now developing their clinical skills. So when we are talking about somatization and mind and body connection, the first and foremost thing that we should as clinicians should be sure of that the patient who is presenting to us, we should always first rule out any organic cause that we can think of. Any patient who is coming to you with any kind of pain, any kind of symptoms that you think, first, what as clinicians, what we do whenever a patient comes to us, she starts giving us her symptoms, we formulate a provisional diagnosis in our mind that this might be the symptom that the patient, this might be the diagnosis that we might reach with these kind of symptoms that we are having. Then we go and examine the patient and we try to find out if our clinical examination is correlating with the symptomatology of the patient, the history that she is giving. And then we, according to our clinical finding, according to the history that the patient is presenting with, we give some set of investigations to the patient to carry it out and then show us the reports and everything so that we can reach a definitive conclusion of the case that is coming to us. Now, if some patient comes to us and we have done all this and we have ruled out that the symptoms are not matching with what the patient is coming to us with, the investigations that we have done have all come normal, and everything that we have tested for or the diagnosis that we have formed in our mind is not matching with the history that the patient is giving. So then the dilemma occurs that if the diagnosis or if the pain that is presenting with us is the typical pain that, or is a another kind of presentation that is projected by the patient's mind. So in such cases, what happened, typical pain will always have one anatomical or physiological cause that will respond to the standard treatment that we give to such patients. But if after doing everything also, if the symptoms are not resolving, the patient is having a chronic history of going to multiple practitioners and none of them are able to reach a definitive diagnosis or the treatment that they have given to the patient has not responded to that treatment, the symptoms that are presented to us are very vague and may be fluctuating with the emotional status of the patient or the stress that she is facing. We should always take the patient in confidence in private and ask her about her family, her social life, her relation with her husband, her in-laws, or her family members. We should always also ask the relatives of the patient also in private regarding what are the patients facing in the home. She might not be able to tell us, so it's better to ask a relative also. So all these symptoms, if we see and then we realize that the patient is having some part of social or traumatic history in the past or some social factors which are contributing to her symptomatology, we can keep a diagnosis, provisional diagnosis in our mind that might be it is not an organic cause, and might be it is a patient is having some exaggeration due to her social issues.
Okay, thank you, ma'am. If when patients feel their symptoms aren't being taken seriously, how do you reassure them while addressing both physical and mental health concerns? Could you share a brief example? Anyone?
Okay.
So, okay.
Sorry, Veena.
Okay, so I'll go ahead. So let's take a common presentation where a woman presents with painful periods, okay, dysmenorrhea, right? So I think while this is very common, they would have consulted many people, they would have done what family members typically tell them to be home remedies, everything is tried out. This is not improving, so then they finally come to you. They already think in their mind that you're going to be again one of those doctors who's going to listen to them, but there is already that diminished sense of hope that something will come out of this consultation, right? Because they've already consulted many people before. So I think at this stage, it's very important that, we don't rush them. We allow them to talk about their symptoms, because sometimes just a very careful and attentive hearing of what they have to tell you is going to first, put them at ease. To also use some reflective statements that you do understand that it must have been so difficult for them to manage, given that this is happening to them over a period of many months or many years even. Right? And to express genuine curiosity to see how they might have coped with this. What have they tried, so that we don't want to suggest the same things that they've tried before and it has not been very useful for them. So very carefully, you're trying to elicit what their, experience with this has been like, right? What helps them alleviate the pain? When is the pain a little more? So I'm just asking questions typically to just get a good understanding of what is going on. What have been the previous consultations that they have made? What have typically been the kind of advice they have received? So I think all of this, when done a little sensitively, when you're trying to also, make them understand that you really get how hard this must have been for them. I think that is very often the first step to first establish that relationship. So I'm not jumping into any solution. I'm not jumping into deciding whether this is organic or whether this is functional, none of those. I'm just telling them that give me a little time. Please be patient. This is the first time that we are meeting, and I'm, really trying to understand your experiences. And I really hope to help you here. So the intention also is made very clear that you really want to help them, but it may take you a little while before you get there. So I think some of these, what we call micro counseling skills, to just engage in this doctor-patient relationship a little, help them at least feel good about that one consultation. They may not leave the room with a solution, but at least they won't leave the room feeling like another wasteful effort, right? You also have to make sure they come back to you, right? Because none of this can be resolved in one sitting. So I think creating that therapeutic relationship a little is what I will prioritize in that first meeting before I get to all other things.
All right, thank you, ma'am. Dr. Padmaja, ma'am, do you think society tends to normalize reproductive pain and discomfort as just part of being a woman? How does this normalization or stigma affect patient care, and what strategies do you recommend or do you use to challenge this? in practice?
Okay. Now, society tends to normalize. Um, in that, we are placing the onus on society. Very really speaking, there is very little society can also do about the pathology of that particular woman. So by society, I mean her family. Let us talk about her microcosm. Okay. So if her family is concerned, suppose it's a unitary family, husband is also going to work and two children are there and she has severe dysmenorrhea because of endometriosis, let us say. So there is precious little that the family can do about it. It is very easy for us to say that she must get those whatever days of compulsory leave and numerous other things that generally we suggest. In every, what you call, in every work system, every public or private, it is not possible for anybody to uh, benefit from those 3 days, 4 days of leave, etc., etc. And how many years? Till suppose she's 58 years, she's going to retire at 58 years. Now, so let us not talk about the society. Society is one part. Society is 50% women who are suffering. Let us say it this way. So 50% of society is suffering. Now, the solutions that we have, the pharmacological solutions are very, very limited. Let us understand this. Why they are limited is, one, there is nothing like a very safe contraceptive. First thing. So, having said that, if suppose a case of dysmenorrhea is there and we want to give her, suppose she has endometriosis and we want to treat endometriosis, all the drugs that are there, they are, if we see, they have a huge impact on her. Otherwise, if suppose we were seeing etiology of premenstrual syndrome, all those medications are the pharmacological agents or the hormones which are implicated in premenstrual syndrome. How do we treat her with those drugs which are implicated in premenstrual syndrome as the culprits? And then we manipulate them by giving those same agents externally. These are the agents that are also likely to have numerous different organ system impact, including breast. Okay. So there is really speaking very little in the armamentarium of pharmacology or gynecology, where gynecological drugs which can help these women. This is really, medicine is an imperfect science in this respect. We have, because whatever we do is not going to change for how many years? From 15 to 50 years. It is not like appendicitis, you give antibiotics, you operate on her and that is done. She's, she's cured. Whatever her problem is going to remain with her till her uterus is removed. And you all might be knowing about the word hysterectomy and hysteria and all that. All of us, we have discussed this terminology, etc., etc. So let us keep all that debate aside. But this is how, if a woman has gynecological complaint, this is her, unfortunately, this has been, her fate is sealed in some ways. Talking about the medications that are NSAIDs that are very likely to have very bad effect on her kidneys in the long term. Well, it is very, the woman is very upset or she is very disappointed when we tell her whatever drugs we give you, either they are going to have this effect or this effect or this effect. And all these effects are temporary. All the benefits are temporary. She will have to take them every cycle, at least for next few months to years. And we manipulate her menstrual cycles. Besides that, we have very little we can offer a woman with, say, endometriosis or dysmenorrhea or, these things. So very tough in some sense for her to come to terms with how she is going to manage it for next few cycles. When it is said that, okay, now her main requirement is producing 2 or 3 children, and then we can do hysterectomy. So this is generally many people think of her, what you call, problem, solution to the problem. That is also in a, I think it's not a very proper solution or a very limited solution, because we are going to remove which otherwise everybody, there are 2 organs in the body, appendix and uterus. We can do away with when the need is over. Appendix, so no need only, but the uterus. Very easy for us to tell. But what are the post-hysterectomy problems that very few of us elaborate on? Younger and younger women are undergoing hysterectomy for various reasons. Younger and younger women are suffering because of the drugs that are being given, and we don't even have data on how many of these women have had which type of hormones in what, how many years, how many cycles have been taken. Had she been given hormones only to manage her contraception, or for numerous other complaints like dysmenorrhea, ovulatory dysmenorrhea is treated with OCs. And so these are the things that we are really, these are the problems that we are saddled with. Let us say, we have very few solutions. We have final solution is, wielding the scalpel. And that is what all of us have learned, wielding the scalpel. Finally, hysterectomy. But this is the problem. Very honestly, not much solution to this problem.
Right. Thank you, ma'am. Now let's see how mental health directly affects reproductive outcomes.
I think Kamaxi madam wants to say something.
Yes, ma'am. Do you want to say? Yeah, sorry.
What
Go
you
ahead.
meant by family or society negating her problem is because the family gets tired and they feel that nothing is seen, so they go on saying that aapka sahan shakti nahi hai. This all happens to every woman. This is part of every woman's life, and how come you are behaving like that? That kind of a thing. So she, inside her mind, she starts blaming herself that, oh, others are also managing and why am I not managing? But there could be, some such things like, people in some houses in Karnataka especially, they have these, not touching in the house and behaving and sitting separately and all that. And a girl goes from a city to get married there, and then she's told, don't touch this, don't touch that. She starts, this is an example, she might think that, something terrible is in me, and that is what is happening to me, and that's why she starts feeling that I should not get periods at all. Maybe this is not really good, or whatever it is, and she's worried that she'll get periods and she'll have to sit separately and all that. Even if she's working, then she comes back and she sits in one corner, and then her pen or whatever it is, that is also thrown out because it has young ink in it. So this kind of a problems also women are could be facing. It's not just generally that there is something very serious with something. When did it start is also part of it, and trivializing her problem could be another aspect of it. Okay.
Right. Thank you, ma'am. So what are the biggest social or clinical barriers to addressing mental health in OBGYN? Anyone?
One small input.
Yes.
Generally, when woman has got a mental health problem or any signs of any emotional what you call maladjustment or whatever you call it. I get worried to call it mental health. It is many times otherwise psychiatrically normal patients. See, if I have limited understanding, but I would like to dissociate two terms, psychology and psychiatry. So many women will have some psychological issues. They are saddled with so many problems otherwise and so many responsibilities. In addition to being equal to men on the work front, they will come home and to prove that they are good enough, they will take on numerous other responsibilities and they will do it to the best of their ability. But this really drains them. All this is fully understood. But we always link her emotional problems or her even psychiatric problems to her uterus and her ovaries. She has the same burden of otherwise illnesses, same burden of otherwise societal pressures that a man may have. So it is not woman is to be treated separately and her uterus as a culprit for sare fasad, the ovaries. And once the uterus and the ovaries are taken care of, her psychiatric problems or psychological problems will be taken care of. These are additional set of issues, but she may have the same set of issues as a man may. So that is one thing that we all must keep in our mind and not treat her as because she has a uterus, she has a problem.
Right. So, ma'am, in your experience, how do mental health issues like anxiety or depression specifically affect reproductive outcome? For example, in patient with PCOS or endometriosis or infertility.
Okay, now PCOS, endometriosis, and infertility. All three are extremely stigmatizing conditions. PCOS because of her appearance. PCOS because of her irregularity of menses. Endometriosis because of the suffering of pain, also suffering of infertility. And infertility, what can we say? Like she is born to give birth to children and she is not doing it. So that is the problem. These are three diseases or three conditions, let us say, that are extremely stigmatizing. They are very difficult to go through. And young girls with PCOS, how they suffer as with body image issues. They, the first thing is lifestyle modification. All of us say lifestyle modification. I can't control what I eat for one day. We expect young girls who are 15 and 16 and 17, when they are trying to enjoy their one social evening with their friends, she has to be reminded, ye nahi khana, ye nahi khana, ye nahi khana, ye nahi khana. How unfair. Whereas all other friends can enjoy that. So this lifestyle modification has become a big burden for these young girls. And what is the other thing? Metformin and hormones. So what do we have? How do we treat PCOS without these three things? Now, how much cooperation and how much understanding of family is required in this, treatment of PCOS, or to take that girl from BMI of 30 to BMI of 24 or 23. It's not easy for that girl. She is trying to look her best because this is a time to look her best, and she is full of acne on the face, and she has receding scalp hair, and she has hirsutism. How is she going to be emotionally normal? She is extremely distraught. And on the other side, she has to perform well in her NEET and in her whatever exams so that she can get admission to whatever courses her parents want her to. Too much complication. This is how I see. I'm not joking about it, but this is the reality. This is the sad reality of a girl of 17 whose BMI is 30 and who's struggling on one side career, on the other side health, and third side is the doctors who can't really help much, say lifestyle modification. Endometriosis, she has crossed one part. Marriage has taken place, or if not marriage, whatever, she has decided how she is going to have her sexual life set out for her. But the pain, which is extremely severe and one of the benign diseases with pain as bad or worse than malignancy. Even if your ovaries are removed because of adhesions, her pain may be there. And finally, what solution? Presacral neurectomy. My God, that's the last solution in our books. Terrible. And now everybody wants to wield their laparoscopes and harmonic scalpels and all that and do treatment. No solution in sight. This is endometriosis and infertility. Now we have surrogacy. But what stigma again, infertile? Women will not be allowed in social functions. Women will be always reminded that you are not a biological mother. She will do anything to become a biological mother. And in so many types, so many setups, it may be the male who may be responsible for all this. The infertility part. So this is how, and imagine in each of this, how much mental pressure and how much psychological trauma she has. She's going through it, she's smiling through it because she has to. This is the thing.
Yeah, thank you so much, ma'am. Yes,
I'll say something, Padmaja. Actually, you really opened this thing of infertility. IVF has become cheaper now. Nobody can say that yeah, it is not affordable. Everybody wants to go for IVF. Actually, person who works for me, she suddenly said that I want some 8-10 months leave because I want to undergo the IVF thing. And a very close friend of mine who was doing this for her at a very modest price and all that. She went through cycles after cycles after cycles and then realized that she didn't want to tell that doctor that her husband is also smart. Now, actually, the doctor is supposed to be finding out that, but somehow that was not done. And then she thought that it is just test tube mein baby aane wala hai, or it is going to be put inside. So that is how the thing. And then she developed diabetes. Because then later on they started with donor sperms, and then she developed diabetes, and then she was pregnant and husband started feeling very worried that the child will look very different than him. Then they had some fight and this girl had a abortion and things like that, and now she's stuck with diabetes. And then again and again that reminder, I should have continued, and why did I feel so depressed that I had abortion. She started blaming, let him fight. No, he was drunk, so he was fighting. I should have just left it to that. And then she's again taken leave, thinking that she'll go for IVF. IVF is become almost like a solution, and it's a very difficult solution.
And let me tell you something about IVF. Unfortunately, see, I am not bad-mouthing my own colleagues, but most gynecologists will not assess a woman before IVF. They are all in their 40s, those women, and they have other illnesses, and they will never be checked. And then suddenly we will come to know she has either a heart disease or severe hypertension or diabetes or some other illness. And now she has IVF. She has she has twins, and she most of them will come with 28 weeks, 27 weeks, and they will expect miracles out of the hospital neonatologists. Make my 700-gram baby survive. What a burden that woman has. So these are the problems that infertility can have on the mental health. And here we never ever do mental health counseling. We are focused like Arjun on the uterus and on the ovaries. वुमन को ब्रेन नहीं होता है ऐसा मोस्ट गायनेकोलॉजिस्ट कंसिडर. आई एम वेरी सॉरी टू से दिस, बट we say that is psychologist problem or psychiatrist problem, and no, it is all our problem, rather our responsibility. But this is how it is looked at. I think Veena will have a lot to say.
Yeah, it was very interesting to hear you both, speak. And I think that amount of critical thinking about whatever we are doing is so important, right? So even as a mental health professional, I can tell you that, so many of us are probably overprescribing, even psychotropics are not entirely safe, right? And that too, so many youngsters with problems of depression and anxiety today, more than ever before. So everybody is getting medicated much more today compared to earlier years. So I think there is a responsibility, irrespective of what professional we are, for us to really think about, how much this is helping and, whether this is really required. Is it causing more damage than good to a particular person, right? So we were talking about PCOS. Lot of youngsters want to be thin, almost thin to the extent of becoming anorexic. So we see that quite a lot with a lot of youngsters, particularly adolescents with eating disorders. Now, this can obviously impact their menstrual cycle, right? And then we see a lot of people being fat shamed because they're on the heavier side. So it's almost like nobody is at peace. Nobody is happy with who they are, the kind of bodies they are blessed with, none of that. And all of these have implications in multiple ways. And it's also very disturbing that when sometimes pain is normalized to such an extent that you should be able to tolerate pain, you're a woman, this is something that all women go through. So why are you making a big deal? Why are you even talking about it? This is something we have all learned to live with, and you also need to learn to live with it. It also delays healthcare utilization. They come to you sometimes after the problem is already quite far gone, right? Problem has already been so chronic. Maybe in the early stages, you could have done something which does not look very radical, but today you're thinking only about something which is a little more radical, right? Also, the mushrooming of ART centers and IVF, oh my God, that is another new level of, disturbing reality that one has to deal with. Yes, today, at least a lot of urban couples are okay with being child-free. They're okay with considering adoption. They sometimes consider surrogacy. None of it is without problems. One needs to understand that, right? None of it is without problems. So I think it's very important also because I work in the perinatal clinic, perinatal mental health services. Oftentimes, pregnancy is so glorified that when a woman experiences symptoms of anxiety and depression, she immediately starts thinking she's a bad mom, to not be excited about having a baby, right? Coupled with so many other social and psychological challenges that she may be going through on the family front, work front, any of this, that could be there. We also see a lot of women who are mentally ill wanting to conceive, right? So this could be women with severe mental illness like schizophrenia, bipolar affective disorder. They would like to conceive. We do a lot of preconception counseling with them. We look at what psychotropics are safe during pregnancy, right? We try to assist them to the extent possible, but it's almost like, everything should be like magic. Everything should just work out. The children, that they give birth to should just be normal, right? So I think there are so many challenges that we are confronting today, and oftentimes perinatal grief, which is, again, not something we are equipped to handle and could be very stressful because, families become a little litigious. They may think that as clinicians, you've missed something, you've not cautioned them, and then they have a stillbirth. So a lot of accusations, on the treating clinician or the hospitals, right? None of this, when, handled with poor sensitivity, can just compound everything else, right? And people can just have poor outcomes as a result of, so many of these things, from the point of care utilization, diagnosis, to the course of treatment, and finally the outcomes that these women have. So I think all of these problems are not without psychological consequences, even if they don't have a diagnosable psychiatric disorder or a syndromal presentation of anxiety or depression. It is likely to cause, some kind of toll on their psychological adjustment, and they will require some support to navigate. Not everybody needs to see a mental health professional. A lot of us work with very sensitive OBG specialists, and they are able to do the first level intervention themselves, and only when it becomes a little diagnosable or, syndromal, do they refer to us. So I think the first level response can be provided easily by any treating clinician. And it's also valued by the woman when it comes from a treating clinician, rather than over referring them to multiple other people, right? Because they also find it logistically a nightmare to go to different hospitals, meet with different professionals. So I think some way we need to also
Stigmatizing.
yes,
Going
and
to a
also
psychiatrist is very stigmatizing.
absolutely, absolutely. Right? So they've come to you thinking that you will solve, but you're, really throwing light on so many other problems, and it's a scary thought.
Funnily, how otherwise successfully reproductive woman, let us say, very bad way to put it, but she has capacity and she has proven her capacity to give birth to children. The trap that contraception has for her, again, the amount of contraceptives that we have and why she is not allowed to do a tubal ligation is because she will be promiscuous afterwards. This is an understanding which some people have. So the control is in somebody else's hands. She may be sort of, morally, her sexual ethics or whatever should be controlled. So this is one thing. Women do not have capacity. See, the family will decide whether she should marry, when she should marry, whether she should give birth to children, when she should give birth to children, how many male children, how many female children, whether she should use contraceptive, which type of contraceptive, everything. Who decides? She never decides. How will she not have emotional trauma because of this? But this is what is never understood, and this is what is never taught to young men rather than the girls. Girls need it, but men have to give it. They do not allow somehow, and this is the trap that the girls go into very easily. And very, very sad to say that even if we have to do a section, no, we will say, "Aapka aadmi kidhar hai?" Admi has to understand, woman, she is uterus. Admi understands, Admi agrees, woman agrees. This is the problem. How are we going to change anything if this is the, on the whole, societal mindset?
Yeah. Thank you, ma'am. On that note, many patients talk about pregnancy brain forgetfulness, memory lapses, or difficulty concentrating during pregnancy. So, how do you understand this phenomenon in clinical practice, and how should clinicians address it without dismissing or trivializing women's experience?
Okay. This is a very what you call a proven entity by research, by biochemical research. The neuroplasticity that the brain is going through, the impact of hormones on the brain, and woman's preoccupation with that baby which is unborn. I won't say preoccupation, but that is most important in engagement she should have, which she has. At the same time, it may manifest to the remaining world that she is forgetful, that she is emotionally labile or whatever. Actually, it should be fine if she is emotionally labile at that time, and it's family's responsibility to support her emotionally at that time. She has, I have seen this thing in our postnatal ward also. Woman, whatever medical problem she may have, day 4 or day 3 of delivery, she wants to go home because there are 3 other children or 2 other children she has to look after. Family is not going to look after those children, though there may be other members in the family. So this is how the woman's preoccupation with that pregnancy, her definitely proven biochemical susceptibility to emotional lability and forgetfulness and memory lapses or whatever. So we have to understand that, we have to allow for that, we have to create solutions for her to tide over this period of pregnancy, especially 3rd trimester onwards till 4th trimester, we say, after delivery. And fortunately, in previous times, pregnancy was a family affair. With whatever the restrictions on the woman, there were many people to look after the babies. Now those many people are not there. Now she is alone looking after many babies. So this is the problem that women have. This is an old time solution which was there, which had its flip side, but it had a lot of positives also. That the families used to look after the other children when this woman was feeding the child and doing things, etc., etc. But this entity is definitely there. We are not taught about this entity of the emotional and otherwise neurological issues that a pregnant woman has. Its association with 3rd trimester and later first part of the postpartum period. And there is very little taught. You all have gone through this. Is anything taught in gynecology? No, it is not taught, isn't it? Gynecology doesn't teach sexual medicine. Gynecology doesn't teach this woman's psychosexual problems or psychological problems or psychological challenges a woman has. We may talk about postmenopausal psychological challenges, but these challenges we do not talk about. So this is what it is.
Yeah. Thank you so much, ma'am. Dr. Shikhanshi, treating patients with complex psychosomatic symptoms can be emotionally draining. So how do you manage this toll in your professional life?
First of all, any patient that you are dealing with, you have to, at the time when you are dealing with the patient, you have to be very empathetic with the patient. You have to listen very carefully. You have to sympathize with what the other person is telling. Be very attentive. Be very curious regarding her complaints, her problems, everything. But when you come back, when you are in your personal field, when you are in your personal life, there should be some boundary that you have with separating your professional and private life. And mentally you should try to either, if you are very overwhelmed with your professional, you can write it down, you can do journaling, or you can uh, just some mindful activity like meditation, you can do yoga, you can do, just keep it separate. And uh, that is how you deal in general with your professional life when you are there.
Okay. On that note, what psychological consequences of OBGYN are most often missed by clinicians, even when physical symptoms are present?
I think Madam has talked about it already, that we tend to miss everything, that even during teaching also, the social, the psychosocial aspects of a female reproductive whole journey that goes through right from menarche to menopause. Many things that are there. We only look at the uterus and pathology. The patient who is coming directly with that complaint, we only will examine the uterus, do a ultrasound, and say everything is normal and send her home. But we should always look and sit with patient and try to listen to her complaints, validate her feelings, all the adjoining her support system, what is there, what are her when she's coming hospital, who is bringing her, what decisions making, everything we should take care, and we should uh, try to sympathize with patient, at least, because we cannot help much with all the everything that is there. As doctors, we can only provide some, give her some solutions orally, but we cannot change the system that is there. So we can just counsel the patient, and we can try to validate her feelings, whatever she is telling, not dismiss anything that she is telling. We should look and try to find a cause and give her closure to her symptoms. And if we find anything that we can treat, it is best for her.
All right. Thank you so much, ma'am. Next question we have is, what would be your referral checklist for gynecologists, that is red flags that signal it's time to involve a mental health professional without making the patient feel dismissed or labeled?
One is patient who has ignored her problems. That is first thing. Because many women will ignore the physical problems unless it is involving childbirth or need for pregnancy. That is one thing. They do not bother about, after marriage, they do not bother about the body image. Before that, they will bother about those things. So they will be very, anxious to get treated. Too much anxiety with body image also creates a problem, because it may be having sexual violence or intimate partner violence, which we generally do not, we get scared to tread into those waters. That's a private affair. But that's it has intimate partner violence has become a big issue in young women who are uh, uh, married as well as in relationships. Okay, this is one thing. Second thing is young girls who are sexually experimenting. Are there, I won't say experimenting, exploration. Sexual exploration starts at very early age. So supporting those girls and seeing if the families can support them at that time in understanding what is responsible sexual behavior. That is one thing that we rarely talk about in adolescent gynecology. So that is one part. After that, women who have perinatal anxiety and perinatal depression. So these are the two things that again we generally do not consider, because it is not very easily, we never ask a postnatal woman, raat ko achhe se soi kya? We will consider that she has to get up 3 times, baby is to be fed. That is understood, but otherwise, is she feeling all right with her health? Is also not. She has so many problems, including episiotomy pain or section pain or whatever, plus this baby's things. So the support system that she requires is one thing, and the early detection of her psychological problems. We have to understand that, like any other organ system, brain is an important organ system, and brain health is equally important. It should not be stigmatized. Brain health cannot be stigmatized. When we say psychiatric health, no, that becomes a big stigmatizing word. I tell everybody, and I tell on every forum, I went to psychiatrist 3 times in very early age because I required help. There is no shame in going to a psychiatrist when you require help. It is important. You are wise if you detect you have a problem and you require help. That has to be normalized first. and our frequent talk with our colleagues in other OPD that I'm going to refer. Now, actually, government has made it compulsory to do perinatal screening for perinatal depression and psychiatric, not psychiatric, anxiety, etc., etc., which, as Dr. Veena said, we should do diligently, and we can reduce the stigma around the whole thing. You know, if I give a questionnaire to a woman, this is mandatory questionnaire, fill this out, or if somebody fills with her, it is important. If I tick mark those many things on that questionnaire, I understand how I require to refer. So these are the things we should be checking out. Young age, little older, young reproductive age group women, then later age group women, and as we say, women before puberty and after menopause are invisible. Women in between are visible because bacha paida hona hai. So these are the problems these two age groups will have, and a mandatory probably sexual health questions in her this thing. We consider that older women do not need sex. That is something that we have created, that understanding, and we must have that in our checklist also. That part of her life is missing. Is it going to have any effect on her? So these are the things I think we must remember to ask.
Okay.
One more thing I just want to say, that I think it is said otherwise also, that if it's a girl child, she has a added responsibility of it is almost like she has given to birth to a child which has some deformity kind of a thing. So she has a responsibility of showing that she next time she'll give birth to this thing, or she's happy or she's not happy just because the family is not happy. And she can't even the person who has given birth to a daughter, she can't even ask for food when she's hungry. So these things can happen to her because they feel very hungry, and when the milk falls out, and then they can't even say that I want to have food because she's given birth to a girl child. These women can have more problem in the because of this social stigma.
So I just want to, add one thing, that as clinicians, let's not be concerned only about treatment, but also a little about prevention and also education, building awareness, working with people much before they attain menarche, continuing to work with people of different age groups, right? So I think that is becoming more and more important today, and to look at health also a little more holistically, to look at all the integrated facets and domains that are interlinked and make up the experience of a woman. All of that, I think, requires a little more attention. So whether it is about prevention of intimate partner violence, uh, teaching youngsters to be in respectful relationships, right? Where they are respected irrespective of their gender, and working with all genders, which I think was a very important point that Dr. Padmaja made. These are also called gender transformative interventions. So the husband's role is not just about giving a ride to the doctor's clinic. It's also about actively participating in childcare responsibilities, actively shouldering some of the responsibilities so the woman gets a little rest, right? To mobilize support of other family members when, they as a couple need it. So I think to go beyond just, treatment is of course very important, but to, just understand that we have a role to play even outside of hardcore treatment, like the student-led initiative of SIMSOG, right? This is also, I think, a great initiative, and you're really, looking beyond just practice and helping women that come to you for care.
We have to learn from them. They realized what we have not taught them, and they have sort of very wise little this thing reminder. Did you teach us this? Better teach it to the next generations.
Thank you so much, ma'am. Dr. Veena, you said about overtreatment. So I would want to ask you that how do you decide which tests are necessary for which tests are necessary for when to focus over a holistic assessment or to avoid over-testing and over-treatment from an ethical standpoint? How should medical professionals balance avoiding over-treatment with ensuring patients feel their pain is validated?
So I don't know if I really have the expertise to answer that because I'm not a medical professional in the first place. So ethically, we all understand that anything that is considered to be not really essential at this point in time can be, avoided, or, it's lower down in your list of priority. Right. So what is absolutely essential, you will start prioritizing those things first, and then, move on to certain other things. So just because these people are covered by insurance, you won't just suggest a whole load of tests, which is happening today in a lot of private hospitals. Right. You also understand that a postpartum woman is already burdened, right? She's already dealing with so much. So I will do what is absolutely essential. So even if it is my psychotherapy sessions for a postpartum woman with depression, I know that optimally for somebody who's not in the postpartum period, I would like them to come once a week. But I know that's simply not practical. Who's likely to engage in this kind of treatment if I expect them to come once a week? That too, wading the traffic of Bangalore, impossible. Even I won't do it. Right? So I think, what seems absurd to us, we should know that, we can't even expect somebody to do. So we should just avoid it. So if I can even do some online contact, even if it is for 20 minutes, because that's a luxury in the postpartum phase, I think I'm, quite satisfied and happy with that. And that way I'm able to at least engage these people in treatment for a longer period of time. The work may be a little slow, but does not matter. I'm prioritizing what is absolutely essential at this point. So I think I will keep some of these reality checks, their affordability, what is it that they can meaningfully do, what is absolutely required, and try and focus, on those and try and prioritize those.
Unfortunately, we have kept general practitioners out of today's healthcare. So if they are, because they are, they used to earlier be considered as friend, philosophers, guides of the family, where they had a big role to play in every decision, the health decision the family made. Sometimes it went beyond health decisions also, but they had a today their limited role is to advise investigations and how much cut to very unfortunate things. So I think it is good to sensitize the family practitioners because they are close by rather than patient being asked to come from one place to the institute far away. Family practitioners are nearby, but that breed is dying, I think, now.
Right. Thank you so much, ma'am. Now, what are the practical structural changes? For example, counseling cells or integrated OPDs could realistically be introduced in medical colleges to support women with psychosomatic symptoms. Anyone?
First thing, screening, which can occur at resident level. So definitely it can be done at the resident level. For that, you don't require a special OPD. In the morning rounds or in the otherwise gynec OPD or whichever OPD, surgical OPD, whichever OPD, there should be that one question on her emotional health or psychological health and sexual health. One question should be there. We get very, see, the problem is in our mindset. Good girls don't have sex before marriage. Yes. That is first thing we all consider, and we don't ask them questions about their sexual health. The problems may be lying over there. If they're coming only for PCOS, are they sexually active? Are they using contraceptives? Are they having some contraceptive which is, or are they having intimate partner violence which is causing them to call it dysmenorrhea? Are they having body image issues? These are the questions that we must learn to ask. We must de-link sex from marriage. That is first thing. Screening is one thing. After that, mandatory questions on detection. Like, see, government had to tell us that you have to ask question on perinatal anxiety. Why should government be required to tell us this? This is actually we required to create the mechanism for this. But this is how it is happening. So that is one thing. And asking about domestic violence. Mandatory questions on domestic violence. The ACOG, American College of Obstetricians Gynecologists, the erstwhile president he once asked a patient, do you have this problem? And patient said, doctor, I waited for 25 years thinking that somebody will ask me this question. This is there on his testimonial. So these are the things that we lack and we must have. Then everything else is smooth sailing. Then referral is easier, but first detection.
Yeah, thank you so much, ma'am. Finally, what do you wish every future doctor knew about integrating mental health care into OBGYN practice? What's one common mistake to avoid? Anyone?
Women are not the uterus. First thing, they all must remember. Women have brain. Women have a better brain, I think. Very sorry to say, because but they manage so many other things, no? So women must be given that due. Women must be screened the way. Otherwise, I think the problem is we don't screen even men for psychological health. We consider only physical health. So these are the two problems. We are actually, see, today for last 1 hour 15 minutes, we have not talked about any other gender than binary. So these are the things, or somebody may be bisexual, somebody may have other orientation. All this has to be understood, and we have to take this as normal, and we have to ask questions. We are nobody to decide how one should be behaving behind closed doors, as long as they're respecting the other person, that person's entity. So these are the things that we must understand. And today's doctors are much smarter, but they have to learn to understand everybody as an individual with a thinking mind. That's all.
Yeah. Any other panelists would like to add anything?
Yeah, actually what she said is very important, that what other gender, which in the beginning I said about transgender and disability, that also will have to find out, because these are the persons who can, because we are talking about somatization where the forced or sexual offense is more common with these people, and these are the people who get affected by that. It could be even a sex worker who could be sexually this thing. So we have to realize, we can't say that, okay, this doesn't happen. And as rightly pointed out by Padmaja, that intimate partner violence is very important, and we have to keep it in mind that it could be there, even if it is a middle class. Rather, actually, in middle class, they might not show at all. Rather, poorer people might openly talk and discuss and shout and tell that, to mele asaच ahe. So that kind of a thing.
So just to add on to that, I would like to say that it's very important for us to recognize we are also from the same society. We are not free from prejudice. We are not free from biases. We are not free from, our own preferences and all of that. But in practice, I think it's very important that we remain cognizant about it, to the extent that we can elevate ourselves, beyond these prejudices and biases, and not make assumptions about people and their background. but to develop a language which is sensitive to ask about all the things that are important, right? Whether it is gender, whether it is sexuality, whether it is violence, these are all very sensitive, very taboo topics. But I think we have to develop a sensitive language to ask and also address it when there are difficulties. So I think that is something that each of us can strive to do. And this is something that is going to be an ongoing process.
Actually, language is one thing. Secondly, if somebody is open enough to talk, we have to keep our mind open that there are other sexual practices. And we can't say that, no, this is the binary alone is there. One has to keep that in mind. It was wonderful. Good. Thank you so much for calling
Yes.
us. I got to learn so much. Padmaja is my colleague actually from KEM, but and very good friend. And it is nice, Veena, to see you, and Shikhanshi, you also. Thank you. And I'm really very happy that, young people are doing this, which is incredible. Thank you.
Thank you so much, ma'am. It was wonderful
Close
having you
open.
all. We'll now open the floor for questions from the audience. Dr. Kriti, I'm sorry, you may ask your question now.
Good evening, panelists, respected panelists. I had a question that we find many cases where there are no anatomical, physiological, or hormonal pathology leading to anovulation or amenorrhea. Can this happen due to psychosexual disorientation or identity crisis?
Padmaja, are you there?
Shall I answer?
Yeah, that's right.
See, there are, you all have heard the terms anorexia nervosa, bulimia, etc. So it can definitely happen with the way a young girl has looked at her life and chosen a particular way of eating style, etc., etc. That is one thing. Second thing is if she is on any medication, because many psychiatric drugs have got hyperprolactinemia as a sort of fallout, and that can cause amenorrhea. And then not forgetting TB, amenorrhea. One of this thing of genital TB is amenorrhea. So we must always not think that it is only physiology and pathology is not there. So these are the three things I would first tick out,
Okay, ma'am. Thank you, ma'am.
Now I would like everyone to switch on their camera for a picture. Okay. As we come close to today's discussion, it is evident that overlap of mind and body in women's health is not just a clinical matter, but deeply a human one. On behalf of SIMSOG, I extend our heartfelt gratitude to our esteemed panelists for sharing their time, expertise, and insights with us. A special thank you to all the participants for being part of this meaningful conversation. Before we conclude, we would like to remind you that the post-event form has been shared in the chat. Kindly, or we will maybe shared within a minute. Kindly fill out to receive your certificate and proof of attendance. The meeting will remain open for the next 5 minutes so that you can complete the form. Thank you once again for joining us today, and we truly hope you found the session insightful and engaging. Thank you.
Thank you so much. I think I also learned a lot, and thank you, SIMSOG, and more power to the students group to organize many more things that you find useful.
This has been a very out of the box topic and a very indeed thoughtful topic for such today's scenario. And I hope I learned a lot from my esteemed panelists, my seniors, and I hope the students have also learned a lot, and they will include this in their future when they are practicing, and when they are practicing clinically on patients, they will keep everything in their mind.